So when we're dealing with heart failure, basically a big thing we're going to talk about is what's the difference between right-sided heart failure, left-sided heart failure. I'm going to talk about some of the causes that are coming out there, what we're going to see with that, what's our signs and symptoms, how we're going to differentiate between those. So we're going to go over our physical exam. We're going to talk about the treatments. We're going to talk about flash pulmonary edema. And then we'll talk a little bit about what they'll do in the hospital as opposed to what we're going to do out in the field. So again, we always have the numbers area in here about who's affected by this, how many cases, where they're usually coming into. Male over female, leading causes. Again, I take these all with a grain of salt. My favorite part. I hate numbers because they don't always apply. Some cases they do, some cases they don't. So I put it up there for you guys' awareness. You guys will be able to look at those. Definition, heart failure. Heart's mechanical performance is compromised, so the cardiac output can't beat the body's demand. So what's the difference between, now we take that definition and we put it to either the right side, and when we talk about right side, what are we talking about on the right side? What's that? Mostly it's ventricle is really where we're looking at. Realistically, we're looking at the ventricle side of things. So when we think of right-sided heart failure and left-sided heart failure, if we look at it, you guys haven't seen a physical heart in your hand yet, have you? Okay. So hopefully on this, you have, well, some people might have on there, but if you look at the atria on a heart, they're really small. There's not a lot of muscular to them. They fill small areas, but really the muscular portion of the heart is the ventricle. So when we're talking about right-sided versus left-side, we're really talking about the ventricles is where we're going to. So where it's pumping again. Yes, it is the atria as well, but realistically, it's the ventricles that's most of our concern. So we're going to talk about each side of those, of where it's going. So this is, again, why we stress the anatomy so much and why we talk about this after MIs and things like that, because now what are the signs and symptoms I'm going to see with each? So I can determine on, is this a right-sided failure? I'm going to see this, this, and this. If it's a left-sided, I'm going to see this, this, and this. So basically with congestive heart failure, the heart stroke volume, and how do we determine stroke volume? What is the definition of stroke volume? Cardiac output times heart rate. Might be something important, might see it in a written format again sometime.
Like Monday morning?
Potentially. Ejection fraction. You guys have seen that before, right?
Yeah.
Again, the difference between the stroke volume and then what's left. So the ejectile fraction is that portion they ejected from the heart, but it's a proportion of what's left over versus what was ejected. Again, you saw that on a test. You might see that again in written format sometime. Could be Monday, could be module exam, could be both, could be not. FIC principle will not be in module 2, but you could see it in midterm. So, and I've not looked at the midterm test yet. So when we're talking about different areas of chronic versus acute, when we're talking about heart failure and that, acute MI that has been going on, previous MIs that's been on there can cause the heart to go into heart failure. Hypertension, putting under stress over long periods of time. Coronary artery disease, again, anything that's putting stress onto the heart is going to be the big thing. Valvular disease, myocarditis, which is an inflammation of the myocardium, can be infection, can just be inflation in there, itis-wise, and cardiomyopathies, just changes there. So these would all be important things to know too-wise in case Gary were to ask you something about what are the causes of congestive heart failure. As far as pulmonary edema, for an acute pulmonary edema or flash pulmonary edema, what are some of the causes from that? Well, obviously, burns we talked about, that inhalation, that injury inside the tissues. What do? We get swelling inside the lungs. Well, what's swelling inside the lungs? Fluid, right? It's flash edema. Cardiac arrest can cause that because now the heart stopped beating. So now any fluid that is flowing into the heart could be backing up and dependent, not lividity, but basically dependent backing up of the fluid. Cocaine and meth, a PE, which is causing a blockage depending on where it is. Near drownings, basically submersions we talk about now is the new change. There's always changes in terminologies. And getting overloaded with fluid. So Again, these things may be important. There might be something, give me 3 causes of chronic heart failure, maybe give me 3 causes of acute pulmonary edema. You guys ever seen anything like that in written format before? No, no, never. So might be seeing stuff like that again. Right-sided heart failure. Basically, the right side is pretty much caused because the left side has collapsed. Left side is usually the most common. What's the biggest muscle in the heart? The left ventricle. Because we're pushing against the resistance, which is also known as the afterload. Might be another good thing to know for future tests. But we're pushing against that peripheral resistance, so that's that afterload. So the left side is usually what we have more problems with left-sided heart failure than right-sided, typically. Again, no always and nevers. So that's where we'll see on that. Other causes are cor pulmonale. This is basically pulmonary hypertension. So because of the pulmonary hypertension, you'll get back up into that right ventricle, and that causes that heart to close down. Key concept, cor pulmonale. You guys might want to be looking into that. So that pulmonary hypertension basically pushes pressure against that right ventricle. It has that backed up. That causes hypertrophy or enlargement of the right side, going to a congestive heart failure, and we get back up from there. Other aspects of right-sided heart failure, pulmonary embolism. Again, they talk about pulmonary embolism causing flash pulmonary edema. It depends on where it is. If you get a pulmonary embolism between the heart and the lungs, basically you're not getting fluid to the lungs, right? So a lot of times the lungs will stay dry. There's other aspects that it can be, but it depends on where it is in there. If you get a pulmonary embolus between the lungs and the left atrium, it's going to back up fluid into the lungs, right? So there is some play on where it is. But if that PE is clotted between the right ventricle and the lungs in the pulmonary artery, there we go. Good job. Then that's what we're going to see is we're going to see backup. And what do we see with right-sided backup? JVD. What else? Peripheral edema. Anything else?
You see symptom changes.
That's usually seen in something else. You can on there, but we'll talk about some other things coming up. But those are where I want you to be thinking about is what are you going to be seeing with those? And JVD and pulmonary edema should be your 2 biggest things. What are you going to see as far as lung sounds? Right-sided. So think about this. The block is between, it's in the pulmonary artery, or the block is because the right side is not pumping sufficiently. So you're getting decreased blood to the lungs. So your lung sounds are going to be clear.
Would you get edema in the legs?
Yes. Yep, you can get it into the arms too, but it's usually dependent. So it's going to back up path of least resistance. You're going to get back up in the legs, so dependent edema. You're not going to see it on your hands so much, but you'll get the backup of the JVD. But the lung sounds should be clear. Now, granted, if I tell you the lung sounds are growls, it could be completely something different, or it could be associated with a left-sided failure as well. But if I want to give you just independent CHF right side, your lungs will be clear, barring any other conditions. Fair enough?
But not for very long, right? I mean, that left side.
Why?
Because that left side is going to start to fail, and you're going to start getting back up in your.
Well, we got no blood going to the left side. It's not going to fail, but the heart's going to be beating fast. You're going to see that heart go into a sinus tachycardia, but you're not getting the output, and your blood pressure is going to start dropping. So there's some changes we're going to talk about that. I'm just talking, yeah. I'm just talking basic on here, the 3 things, if case that you see it again in written format another time. If I see right-sided CHF, what do I expect to see? I expect to see JVD, I expect to see peripheral edema, and I expect to have clear lung sounds. Generalities. Fair enough? And then remember Starling's law. Does everyone remember Starling's law?
Yeah, but let's go over it one more time.
Just whatever you put in is what you're going to put out. So the more stretch you have, the more pressure it's going to be to push out. The little bit of stretch, the little bit of pressure back. So basically, in a nutshell, the more blood filling we get, the bigger contraction we'll get. If we have right-sided failure, how much filling are we going to get in the left side? Minimal. possibly none if there's a PE, but let's just talk about right-sided failure. It's decreased. You're going to get minimal filling compared to normal on the left side. So the left side's going to get minimal force of contraction coming out. So here's that scale, basically talking about where the blood goes. So you can look on here, and I'm going to go with my pen format on here. So right-sided failure, here, blood is not getting pumped up adequately to the lung. So we're getting reduced amount out, and we're getting backups here and here in the superior and inferior vena cava. Other signs and symptoms you're going to see with this, you're going to see the patient's obviously going to become tachycardic. Why? Well, basically for the purpose we said, we're getting decreased blood supply out, so it's going to beat faster. It's going to try and get more out. I talked about JVD. How do you see it? Patient in a seated position, reclined at a 45-degree angle. You're going to see edematous, mostly through the lower extremities, but it's going to be peripheral edema that's going to be backed up. When blood backs up, where does it back up to? Well, it backs up to the extremities, but also to the liver, so the liver's going to get engorged. So we see CHF, cardiomegaly, other issues. We'll usually see hepatomegaly can back up because the blood's going to back up into that filter. Yeah.
So with that, would you also, you were talking about palpation of the blood, that distension right below the cage of the liver?
Not on an acute side, but chronically, yes. You can see a hepatomegaly from it being engorged. Ascites is going to be associated with this. Same thing aspect. You get the liver problem backed up and it's having issues on there. Now you're going to get ascites built up. They're usually going to be hypertensive from some of the states. There is that back pressure, but again, they're not building up. They're not going to stay in that state for a long period of time. Usually associated chest pain and different arrhythmias we're going to see with this. And you can see from the picture. So again, if I tell you right-sided heart failures, tell me some symptoms, signs and symptoms we might see. These would be good ones to know. Fair enough? Yeah.
What's ascites?
Ascites, again, is fluid into the belly or into the abdominal space. And it's, I refer it to the waterbed type thing, where you hit on this side, it does this wave that comes across. It's basically, imagine a tender with no ballast. Fluid moving throughout, but it's in the abdomen. And in fact, this picture, that's ascites right here, where this whole belly, just imagine that the whole thing is just filled with water. I call it water. It's not water, but you get my terminology. Yeah. I'm dumbing it down here.
Thank you.
I gotta bring you to my level, where I'm at. Just down here.
Because I'm trying to make me feel good, but they usually stop talking about it.
That's true. Spokane does not have. What's a tender? A tender is a tanker. Okay, left sided heart failure. Okay, now this is going to be, we talked about what we're going to see from the right side. Now we just think about the left side. Same anatomy, same everything that we're going to come through. This time now, again, the left side is not pumping well. So where does the fluid back up there? Which is the pulmonary vein. It's going to be backing up against. Okay. Just going over anatomy questions. It might be important sometime. I don't know. So, so we're going to see that back pressure building up through in there. It's technically going to be up from the atria. Everything is going to kind of back up in there, going to cause problems through there. So if we go through our anatomy again, now we see left side is our issue. And from our lungs, we see the backup into the lungs here. So now we're not pumping out into the system as well because we don't have as much blood. We're having that weaker function. It's not still getting in. It's backing up to the lungs. So now, am I going to be peripheral edema? Actually, no, because I'm going to back up to the lungs. I'm not going to be backing up into the right side because the right side is still pumping up effectively. Over a chronic time, am I going to see it? Absolutely, because my left side, as we talked about, is going to cause my right-sided failure, which is going to cause backup. So we're going to see that coming over. But initially, what I want you to know, again, these are just general basic terms on this. Coming up, when I see left-sided, what am I going to see for lung sounds? Now I'm going to hear wet, rouse, junky, but more wet. What I want to get from it. So I'm going to have wet lung sounds built on there. But my outside extremities, I'm not going to see the edema, and I'm not going to see JVD. Again, generalities, not in the acute stage. So what are some of the causes from that? Well, MIs. There's problems with the heart. It's had areas that it's died. There's weakness in those. That's going to be the big one. Hypertension. Basically, hypertension, you're going to see that's going to cause back pressure. That's your pressure your heart's got to push against. So that's going to have an issue backing up. All types of arrhythmias and cardiomyopathies. Again, if I tell you what would be some of the causes of left-sided heart failure, a couple of these would probably be a good thing to know.
So for right-sided, it can be caused by AMI.
Absolutely. So if it was on the right side, why would the right side be affected by a MI? Well, or an inferior MI. You think about the position of the heart. These are things I want you to start working at too. So an inferior MI, which affects the right ventricle. So, and if we talk about an MI that involves the anterior aspect, left ventricle. If it involves the septal region, what's in the septal region?
Right on the branch.
And? Well, if the right bundle branch is there, then the left bundle branch is there, right? And the bundle of His. So basically, that's where it's going to affect. So think about those spots of the anatomy in there. So if I have a septal MI, what's it going to affect? Well, it's probably going to cause me a bundle branch walk down the road because there's probably damage to right, left, potentially both. I just want you to be thinking about these things. Don't worry, we're not talking bundle branches yet. But I want to, again, I'm pushing this out there. You all right?
Oh, I need more. Yeah, I was just thinking. Out loud. Sorry, I need more coffee.
Fair enough. I'm right there with you. Don't worry. If you guys haven't got a clue, I'm trying to give you the things you need to know and the things you don't need to know out of this lecture. Is that fair? Okay. Perfect.
Just know all the signs.
Yeah. No. But thanks. Signs and symptoms. Again, right here. You guys know what I have to say about this, right? I'm not going to repeat myself on that part. You guys got it down. As far as your cardiac assessment, and here's again, this is a point Shane did assessment last night for EMS Live, and OPQRST and sample history. This is constant through everything we're doing. This is basically not just on. This is on every patient. You should be asking these questions. But when we're asking this, how does this occur? Usually gradually over several days. Well, these could be people who are chronically have CHF and they have flaring symptoms, other things like this. This can be over years. What causes it to be lying flat? Usually people are going to be sitting up. They usually have other problems associated with too. And we talk about 3 pillows or sitting up and being more in the tripod position. Yeah, all different type of things they go through. They're usually going to have chest pressure, but this doesn't have to be associated. They could have chest pain. It may radiate, it may not. This may be the worst episode they've ever had. They may have diabetes associated with this, and this is like a silent. They're not really noticing on there. These usually you get called in the middle of the night. Why would you get called in the night versus the day? Because they're laying down. It's going to exacerbate the conditions. Yep. Because they're up at 3 a.m. and we should be too, right? And then previous histories that you might see associated with this, almost if they don't have COPD, they may develop COPD because of this. Which comes first, the chicken or the egg, CHF or COPD? So hypertension. A AAA could develop this normally because of hypertension. Could be other aspects here. All these things are basically going to be big factors in their previous histories that they're going to have. I do not know what this video is, so let's take a look at it.
Never say that when you're raising kids.
Well, hold on. Where's my... Okay, give me a second to... Oh, we had an interesting experience last night that I got to tell Mo on. So yeah, here's the thing too. If you guys are ever doing what's called a webinar, if you can have access to mute people's buttons, it's a fantastic tool to have. So when people decide to have an argument and the F-bombs are dropping in the background and you're telling them to mute their mic and they don't hear you because they're in an argument, that's always fun. So it was interesting.
When a person has heart failure, their physician may tell them that they have an ejection fraction of a certain number. What does this mean? The ejection fraction is a measure of the heart's squeezing ability. On the board, I've shown the heart in relaxation or diastole, and the heart in systole or when it squeezes. The difference between these two measurements is the ejection fraction. It's measured in percent, and one would think that 100% is a normal ejection fraction, but that's not true. The normal ejection fraction is between 55 and 65%. That is, a little more than half to two-thirds of the blood in the ventricle is ejected with each heartbeat. Well, there are many numbers for ejection fraction, and they can range from normal to quite impaired. On the board, I've shown a normal ejection fraction, 55 to 60, and a severely impaired ejection fraction of less than 20. It's important to remember that these ejection fractions are not precise. The techniques for measuring them, such as echocardiography, nuclear scanning, or cardiac catheterization, have a fairly broad range. So you should think of the ejection fraction not in terms of a precise number, but in terms of a broad general rating. Patients tend to be obsessed with ejection fractions, and physicians are not. We take this information, we store it in the back of our head, but we're more interested in how the patient feels and how they are doing than the actual number. So when you hear the word ejection fraction, it's a measure of how well the heart squeezes, and it is one of many things that are used to assess heart failure. When a person has heart failure, their physician...
And I'm going to watch that. Come back. All right.
So we don't need to know that, but keep that in the back of our head and see how it's.
Well, you need to know it. That basically defines what it is. I want the actual definition of what it is. It's a percentage of what blood flow is ejected versus what's left into the heart. But just to let you know, yeah, the heart, when it squeezes, there's always residual that's left into it. Same as when our lungs, when we breathe and exhale, we always have a residual volume into the lungs. So.
Should we know those ranges?
Nope. Far as medication history, different things you may see them on. They may be on different type of diuretics, loop diuretics, furosemide, bless you. Usually they're going to be on antihypertensives, again, because what potentially causes CHF? Hypertension. So usually going to see it on anti. ACE inhibitors, beta blockers, bronchodilators, digoxin, nitro. All these things are potentially going to be medications they're on. Have you guys gone over ACE inhibitors, beta blockers, digoxin yet? A little bit? Okay. I just got to get a range because I'm not here obviously every day with you guys. So just want to know where you're getting at too. So we'll probably be going more into those if you guys haven't got a good view of those. Do you guys know medications that are beta blockers? Toprol. You went over there. Did you go over lisinopril? Okay, so you have perfect. Okay. You guys know that. All right. So
Craig is not a good representative.
he's not speaking for the general knowledge of everyone. So okay, so then we'll pop that on the test. So know what beta blockers do, and no, I'm just
Well, the great chat was special test.
yes.
That's right.
Okay.
I wouldn't even score high. I went to high school for you. That was last.
All right. So what's the treatment for this? Obviously, the big thing we want to do is we want to get a 3 lead on everybody, and we want to get a 12 lead. We want to see what's going on, check what there's, because what's an associated thing with this? MI and different cardiomyopathies and different rhythms that we can see, arrhythmias, bless you. So we want to be checking that out. We want to put the patient at rest. We want to get him in a seated position. So when we transfer this patient, we want to basically get him up, walk him down the stairs, take him out to our stretcher, right?
Yeah, maybe get on the treadmill in between to try and get that.
No, this is the patient you do not want to move. You want to carry this patient. Yep, you want a stair chair, you want to lift them, you want to do something else on that. You get this person walking and exerted, you can get them into a flash pulmonary edema. So you can cause that. So this is the patient you do not want to walk, depending on how aggressive that is. There's people who live with CHF. Okay, take it with a grain of salt. But I want you to be thinking about that. Someone is an exacerbated CHF, especially left-sided on there. This is not the patient you want to walk and overexert because you can put them into a flash pulmonary edema real quick on that.
Some of these patients actually know what their ejection fraction is, so to ask them. I mean, my bottom line is an example when he was at his worst was at 15%, which is very severe. And so these patients aren't circulating blood, which, you know, when you put that exertion on, the heart's not going to do it, the body's not going to do it.
Yeah. Yep, and they are very aware of that, of exactly where they're at. And like I said, they're more aware of it than their doctors are. So, O2, be prepared for what you're going to do for this patient, how you're going to manage the airway. If they do have some pulmonary edema, what's our #1 treatment for pulmonary edema? You guys should be thinking CPAP. Nice little hint right there, huh? So that's what you should be thinking. Do I give this patient nitro? Absolutely, you can. Be considering that. If my patient has associated right-sided MI, do I give them nitro? After I got an IV established and be prepared for that. Now, am I going to dump fluids on someone who has a pulmonary edema? No, but I want to have it established for what I'm going to do. So, but no, I'm going to be considering that. Why would I consider dopamine? Fantastic. So would you think about, because dopamine is going to be working on what type of receptors when we talk about the alpha beta? Depending on what volume, right? Depending on the dosage we're going to give on there. Because what's the lesser dosage? What does that work on? Alpha 1. Do we want alpha 1 properties? Are you sure? Because that's going to cause more hypertension. Depending on which situation. Are we dealing with right-sided or left-sided? That's where you got to go on to. So but if we want contractile, what is that? What property is that? Beta 1. What was my dosage of dopamine for beta properties? 10-20, 15-20, higher levels. Beta in the higher levels, alpha in the lower levels. So again, I want you to be considering all the things that you're going to do. So if we give a medication, we got to know why we give it, right? So these are the big areas. So this is why alpha 1, alpha 2, beta 1, beta 2 properties are important, and you know which medications fit in what. Yes, sir.
Don't you talk about how if you exceed a certain value that you can know beneficial properties? Oh, is that something else?
Yeah. There.
Okay.
Yeah.
So let's say you're teetering on that edge. Are you going to get no beta 1 effects at all, or is it going to be just like boom?
Teeter and what edge?
Alpha 1, beta 1, and then it's
You've got a mixture in that range between 10, 15. You're going to get alpha 1 and beta properties because you're getting into those range. But do I want beta? I'm going to be 15 to 20. Do I want alpha? I'm going to be 2 to 10. Try and keep it in those aspects. And that's where we talk about, someone was saying, you know, how do we start a dopamine drip? We put it on and do it wide open and we titrate? Well, yes and no. Can you do it? Absolutely you can do it. Do people do it? Absolutely they do it. I would rather you guys be more precise. Once you guys leave the class, if you guys want to do that, fantastic. You guys will learn how to do that. But in the class, that's how I guys want you to think for it now.
Figure out something.
I'm not teaching you to do open wide, is what I'm saying. I'm teaching you to do this. If you go out and practice later and do it open wide, hey, I'll never second guess you guys.
I'll give you the credit for it, though. I'll give you the credit for it.
I don't. I won't second guess any people out there because I'm not there and I don't want people second guess me when I make my decision.
Oh, no, you'll
So-
never ask us a question that seems like dermatomes and all.
Oh, why you're a student, I will. Heck yeah. That's a given. I just wish I could be a couple of you guys as preceptors. That's always fun. So I don't work. I'm not a full-time employee anywhere besides here, so I wouldn't be full-time riding. So Oh, I can- yes, but I can't be a full-time preceptor. And trust me, I have students do ride with me at certain times. If you are riding with me, not necessarily a good thing. Just giving you out. That means I'm watching you closely. So if you're riding with me because I said, hey, come ride with me, not necessarily a good thing. Fair enough? Okay.
So if my schedule pops up with just
Yeah, just be looking right there. Yeah. Let me see. I like Crown Royal. Just bring me things. No, I'm just kidding. So
Does Gary precept at all, or?
Gary has Gary and I do not precept. and Gary will be out for a long time, but he and I both have had people ride with us before. Again, not necessarily a good thing unless it just happens to be. Okay. So as far as this, again,
Good question, actually.
nitro can be given. We don't use Lasix anymore, but again, our dosage of Lasix, they're talking about 40 to 80 is our typical area. I want you to still know what dosages are. Spokane County, our protocol was double their daily dose. That's how we started out. If they're taking Lasix already, we found out whatever their daily dose is, and we just doubled it. That's what we started with. For National Registry, I want you to know 40 to 80 is your range you're going to be starting. Question.
Is Lasix out of our county protocol now? Because we still carry it.
It is out of Spokane County's, well, no, let me say this. It is out of certain departments' protocols because we're not carrying it. Your department, you may have Dr. Haggerty says, yep, you guys carry it, and it's under your rules. So
Never seen it used or
Okay.
any reason, but
So-
it's there.
you may see it come back, you may see it, you may not see it, it's just wherever. But again, you're under Dr. Haggerty.
Yeah.
So Dr. Haggerty can do whatever he wants within his area because you're under his license.
So just real quick question on this one. So it's a loop diuretic, which means it absorbs or just makes you pee more.
Correct.
So how fast does that actually work with someone with CHF?
On
I mean, like, or how
with
fast?
CHF, not so much. With pulmonary edema, I've seen it work very fast.
So like and
The
then-
fluid, they don't start peeing immediately on there, but they start filling their bladders, and it
Oh,
gets
okay.
the fluid out of the lungs. But it does work very quickly. What's your experience with it, Maurice?
Yeah, I've got very limited experience. 'Cause when I started as a medic, we stopped carrying it.
Okay.
But, you know, if a patient is already taking furosemide, there's no reason why you can't do a quick call to the ER and say, hey, doc, this is what I got. I want him to take it. Like, I've done it before where I had him go in and take another dose of their own personal furosemide, so we get that treatment going earlier.
Yeah.
Before transport. So it's,
The times I've used it, I saw a pretty rapid effect, but I see better effect with CPAP.
Yeah, is that mainly, so loop diuretics are they mainly ACE inhibitors? Okay, versus osmotic diuretics, which are.
Yes, because it works on a different area. Correct.
Why is,
And I can talk to you more about that specifically if you have the question. I won't bring everyone into that conversation right now. So- What?
Why is morphine up there?
Why do you think morphine's up there?
Chest pain?
No. What else did it do? Why do we not give morphine? Causes hypotension, right? Is what they talk about doing, and it opens up the areas. That's one of the reasons. But you can have pain associated with this, not common on there, and that's not the purpose in there. But as I said, it's fallen out of favor, and you'll see it's usually not even in our most of our treatment plans that we're talking about now. Hold on one second, Dr. E. Hey, Joel. Good, are you? Yes, are you? Well, do you want a badge buddy type thing for ages, or do you want one specific? Are you on a call right now? Okay. How soon do you have to have it? Oh, yeah. Let me call you about that at lunch. I'm just lecturing to the students right now, but I interrupted when I saw your call. What's that? Yep. Age. I'll call you back at lunch. Thanks, Joel. Christina was on a call with a 10-week-old infant. I am now instructing and I'm part of this hand-Tevi system, which we're going to teach you guys. And I got a phone call from Dr. E and Casey Austin while they're at a 10-week-old, and they started asking me for drug dosages for the things that are going on for kids. Because I'm the only one in Spokane County who's an instructor and who has all access to that. So that's part of the reason why I take his call, because then he starts asking me for screenshots for drug doses for a kid, and I'm like, that's why I said, you're not on a call right now, are you? So, but I'm actually getting phone calls from certain people, so I apologize for taking it during this, but that's why. So, what's that?
What's a bad buddy?
Badge Buddy is a little card that has different ages with kids, and it has certain drug dosages for certain cardiac drugs. You guys will get that too. So, yeah, but he needs it for a specific child. He wants to have the drug doses all set up. So in case something happens and he's being released from the hospital and they want to have it. So if crews show up to the house, mom can just pass them this sheet so they don't have to call. So, yeah, because it's a kid that's probably going to have problems down the road, unfortunately. So, flash pulmonary edema. Again, this slide would be important to know. Rapid onset, usually this comes very fast. It can be an exacerbation from an MI going through. It can be congestive heart failure that coming through. It could be something that just be acute that's bringing it up. It could be a submersion injury where you start just getting some fluid in there and you get some irritation and it just kind of responds. Obviously, we talked about burns. We talked about other issues as well. Most of these patients do respond to diuretics very well. Diuretics work fantastic, but we'd rather try nitro and CPAP. It's going to be probably one or two things. CPAP first, nitro being followed. That's going to be kind of the ones on there. They talk about morphine sulfate, but we don't even carry it in most areas, so it's dropping out of favor. All right, let's.
Is that what happens in parking lot drownings?
What do you mean by parking lot drownings?
Gets
Do you mean like dry drowning? Like dry drowning? No, I wondered if like dry drowning instead of parking lot.
Yeah. It's like
Come
when
back
somebody
here.
goes to the beach and they go swimming and suck in a bunch of water.
An hour later.
Okay, so that's called a dry drowning.
Yeah.
So, I'm gonna pull that one until we do submersions.
All right.
But yes, it's similar to that though, where they can get that flash, but they get fluid into their lungs, and yeah, it causes that response, and then the body just has a reaction, knocks surfactant out of the way of things too. I got to get back to where I'm at. Yes, Jeff.
I just thought it's like burns. You really want to be more looking to innovate to see back. You might just jump to innovation and then get nitro. For burns, for like, you got a burn patient.
What would you do? Yeah. So what would you do for a burn patient? Obviously, for a burn patient, yeah, totally different story. So if it is for burns, yeah, absolutely, you want to be protecting the airway. You're absolutely correct. Yep, I agree. So if you did have that, if it's a flash pulmonary edema due to burns, you're worried about the airway swelling. So yeah, you'd be doing that one. Would be
Just go to nitro after.
well, you'd go to you wouldn't necessarily do nitro because in that case, because now your patient's unconscious and we don't have any other way to do it because it's not there. But what you would do is after you got the intubated, you protected the airway, you'd be using PEEP and getting positive pressure ventilation similar to the CPAP. So that would be the difference.
Okay.
Yeah, good question. So, Did I
Along
go-
those lines, if for some reason, let's say the agency you work for doesn't have PEEP, is there any other solution to that?
there is, well, you could get the PEEP. Those are really easy to do. The rescue pods, if you're doing, work fantastic on those too. Actually, we got an expert right here. Let's ask him.
If you don't have a deep valve, if you're practice a lot, you can learn how to do it deep with a bag. Extremely difficult.
Hold your hand on the end of it.
Yeah.
I would say talk to your agency and get it.
Well, I appreciate
Or if you've got a tube in place, you get a rescue pod. That's
Actually,
supposed to-
the rescue pod is actually the opposite.
Oh, I thought it was supposed to hold back pressure.
It actually creates negative pressure.
Oh, fair enough. Good to know. That's why I don't use a rescue pod.
What's your take on rescue pods then?
I think they're great. And look at the way they work and the studies that they do. They increase cardiac output.